those who are attending from elsewhere. So great to have you, and thank you.
Thank you very much, and good day, everyone. Here I'm calling from Vancouver in British Columbia, where it is just about the beginning of summer here, as I think you will get a bit chilly on your side. Thank you for the introduction. I'm going to chair the session today on APL. I'm just going to try to share my screen just with a couple of introductory slides. And hopefully you can see my screen now. Okay, there we go. Prof. Lowe already gave me a very warm introduction, and I am based in Vancouver, but have very close connections to South African hematologists, particularly those at UCT. I am currently the medical director of the stem cell registry and cord blood bank with Canadian Blood Services. That is at least a chunk of my responsibility here, but I still have some actually responsibilities in general transfusion medicine at Canadian Blood Services. And I'm very rusty in that area, so I'm quite keen to attend any deep dive sessions that you have in transfusion medicine for my own educational sake, please, Estelle. With respect to APL, I actually think it's the first hematologic malignancy I ever saw. And of course, often the first thing you see is the thing that you attach to very closely. I was shown the patient and some peripheral blood slides by Professor Nowitzki and Professor Mike Dutoy. Those names will be familiar to some of you who are of a certain generation. For those who are on the young side, these were formative teachers at UCT until recently. So I've retained an interest in APL for lots of reasons. It's sort of a hallmark hematologic disease, and particularly in the world of leukemias. And I'm glad to know that there's so much interest in it still. So today I'm going to be assisting two key speakers here, and those who you already know about, and we'll start by introducing them briefly. So Dr. Deline Creel is going to be giving the first talk, and her talk will be entitled The A to Z, or as they say here, A to Z of APL, bed, side to bench and back. And I couldn't imagine a better example of a disease for that discussion. And Dr. Creel is a hematopathologist based in Cape Town with the group at Acute. And that talk will be followed by a discussion by Dr. Perry Liebenberg, who I know about, and thank you very much for agreeing, Perry. Perry is a clinical hematologist, recently completed his training, and is now in practice at the Constantiaberg Clinic. So we have a nice breadth of discussion, including pathology and clinical hematology. And my hope is that we'll have time for discussion as well. So welcome, Deline and Perry, and thank you for talking. And I'm going to ask Deline to take the next steps. And I'll stop sharing my screen. So that's great. I can see your slide, Deline, so that's excellent.
Perfect. Thank you so much, Matthew. I'm going to go right ahead since we do not have a lot of time to talk about this interesting topic. I'm going to run through the slides quite fast, and thank you so much for having me. I think we can talk much longer on APL and the laboratory and the pathology side. So these slides will be available afterwards if you want to email me or find them in the library to go through at a bit of a slower pace. hear me. There we go. Sorry about that. I was saying I'm going to run through the slides quite quickly in half an hour, and you can go through them at your own time from the library afterwards, since there's actually much more to say about APL, and thank you for having me. In the WHO monograph, you guys will find APL with PML RARA under the AMLs. We know that there's a younger cohort of patients that present with this type of AML. Remember, if a patient had previous chemotherapy or topoisomerase 2 inhibitors, for example, you need to label these APL cases as therapy related. And APL is important because the diagnosis is an emergency. You need urgent specific treatment, and often for us in the laboratory, the initial suspicion of APL is based on your subjective findings on the blood film. So that makes it really important for us at hematopathology to suspect APL correctly and when indicated. And also you're dealing with a population of younger patients with very good outcomes if they are managed appropriately in the acute setting. Just trying to move my slides along. There we go. So APL biology, as many of you will know, the genetic hallmark is translocation 1517. That's balanced and reciprocal. The PML gene and the RARA gene, that is your promyelocytic leukemia gene, and that's actually a very convenient abbreviation, where RARA is your retinoic acid receptor alpha. Your breakpoint at PML varies. That gives you 3 different isoforms, and you guys will remember that although the vast majority of APL cases you can demonstrate your classic translocation 1517 on karyotype or FISH, there are the rare cryptic or masked ones where you need your PCR to demonstrate your transcript. And then a small number of cases of variant rearrangements where RARA has a different partner, and especially ZPTB16 and STATB5 are important here because they've got treatment implications, and treatment response is not good with ATRA, and we'll get to that later. There are others, more than they used to be in the past, and you will classify these separately in the WHO classification. So since time is limited, I'm not going to labor the point here. You guys can go through this in your own time. Normal RARA is a go, no-go gene. You have got, without your retinoid ligands, you have got switching off of transcription because you've got binding with RXR, and you have a whole co-repressor complex that is assembled and does not allow transcription of target genes. As soon as you add the ligand, you can actually then recruit co-activators, and you displace your co-repressor complex, and transcription is allowed. So no go and go. Versus your normal PML, where the function is not fully elucidated. However, we know it encodes a family of proteins in the nucleus, and this gene is involved in control. So tumor suppression, genomic stability, P53 dependent growth suppression. And if you have these two juxtaposed and you've got this new fusion protein, you take your RARA and the function that we just discussed, and you go from a go, no go to a definitely no. So there's more avid binding to your co-repressors and to your DNA, and you have got potent and constitutive repression of transcription. So that first step without your ligand is persistently present, and you actually need pharmacological doses of retinoic acid to overcome this block. And this is what is exploited with ATRA. A quick slide on the hemostatic dysfunction in APL that's important for our trainees. There is mortality that remains and morbidity, surely, from the specific hemorrhagic syndrome that's associated with APL. So at diagnosis, you can often see features of primary hyperfibrinolysis and consumptive coagulopathy. And this is very important to think of as soon as you see the patient and you suspect AML, APL, because they can go on to develop intracerebral or pulmonary hemorrhage. Rarely thrombosis predominates, and the mechanisms are discussed here at the bottom, which I cannot go into detail about now. Clinically, your patient often presents with symptoms and signs of severe thrombocytopenia and bleeding that's associated, as we know, with a low platelet count. Also features symptoms of anemia, constitutional symptoms, and then, like we just discussed, DIC-related more catastrophic bleeding. This is the 39-year-old lady that we'll just use as an example. She presented to the peripheral clinic with a platelet count of 8, also a severe anemia, not a good reticulocyte response to her anemia, fibrinogen of 1D dimer more than 5. We could see the INR was edging up while the PTT was still normal. And we will look at her morphology and her cells as we go along. On the differential count, 70% of her white cells were abnormal promyelocytes, but as you saw on the previous slide, the white cell count was actually within normal limits. So characteristically with APL, you can see a marked thrombocytopenia. That's classically what you see with a normal white cell count and a reasonably preserved HB. In the current case, they had already been bleeding, and the patient was also HIV positive with competing causes for an anemia. So the blast equivalents are your abnormal promyelocytes, and there's a differentiation block at the promyelocyte stage. So you guys will probably remember the bulk are hypergranular, or the more typical APL promyelocytes, whereas 25% of cases are microgranular, not truly hypo or agranular because the granules are there, they're just difficult to see. Both types are associated with this hemorrhagic syndrome we just spoke about, and especially the microgranular APL is even more prone to the coagulopathy. So looking at the promyelocytes themselves, especially with a normal white cell count, they can be very scant on your blood form, and usually you see more on your aspirate. They show a very variable nuclear size and shape, and classically in the literature and in your textbooks, they'll be described as folded or wasted, some reniform forms as well. The hypergranular form has got large and dense granules in different colors that can be so dense that they obscure the nuclear border, whereas the microgranular variant are more dust-like. And everyone just please wants to find the hour rods and also the bunches of hour rods in faggot cells, because this is very helpful if you can find them. As we will see on the slides to come, you may have an APL with a very deeply basophilic cytoplasm, which can be confusing. So let's talk about that in the next slides. So here we can see the classic morphology that the textbooks tell you to look for. You have got lots of hour rods. You've got a very granular cytoplasm, as we see in normal promyelocytes. You can see an eccentric nucleus, but otherwise just folded and really abnormal or hourglass shapes. But as you will see in the next slides, it's actually a bit more complicated than that when you start working on the bench. So challenges include the microgranular variant or type of APL that we just spoke about, that can look very similar to monocytic precursors and monoblasts. The hyperbasophilic APL, which I show here in a separate picture, very basophilic cytoplasm, limited cytoplasm and blebbing, they can actually look like megakaryoblast, and they are often seen at relapse. And then the variant RARA translocations that we spoke about on an earlier slide can make things more complicated with the absence of our rods and some maturation beyond the promyelocyte stage, where you can then see abnormal neutrophils as well. So this lady we just spoke about, the 39-year-old with the abnormal promyelocytes, had some unassuming looking precursors or primitive cells in her on her blood film. So when you see these, you think there's definitely something wrong and we need to do a bone marrow and do the entire workup. But these do not immediately jump out at you and tell you, listen, consider APL. So as soon as you see some abnormal cells, it's important to go and look for as many others as you can find and assess them very carefully. So what we see in these examples are actually folded nuclei that are shaped like a fat C shape, and we now know this is confirmed APL. So you guys can believe me, this is what they looked like. And we did see dusty, dust-like granules in the cytoplasm, but definitely not the classic hypergranular promyelocytes with our rods and faggot cells at all. Over here, it looked like you wanted a thumbprint indentation that we see with FLT3 and MPN1, but actually you pressed your thumbs all the way in. So a very folded, a deep cup invagination. And then these examples just show that even if your granules are difficult to see, if you look closely, you can see on the one side of these abnormal promyelocytes, there's an eosinophilic U that you've got on one side and not on the other. So you've got a concentration of dust-like granules sitting on the one side and not on the other. So all of these have got a pink side versus a more basophilic side. And these are just examples of how challenging it can be to make a call to give ATRA because it might be APL. A single promyelocyte had a more distinct APL-esque nucleus. And a quick aside is to remember to look in the trail of your slides where your cells are degrading and maybe even dead, because sometimes you can see our rods and the faggot cells more easily there in the tail, even though the cells are not completely intact anymore. A few quick words on microgranular APL. The white cell count can be higher, and you've got more abnormal promyelocytes circulating, but although there's more of them, they are more difficult to call as APL promyelocytes. Like we said, monocytic differentiation can make things very hard. Look for some bilobe nuclei, and as we said, a higher incidence of coagulopathy associated with your short isoform and also FLT3 internal tandem duplication mutation. And for your interest, a paper here at the bottom that tells you of the different kinds of AMLs that can fool you and make you think or make you miss a microgranular variant. So coming to further tests that you would do on your patient, cytochemistry if you're removed from flow and FISH, with strong NPO and some weak positivity in non-specific esterase, which I won't delve into now. On flow cytometry, side scatter is helpful if you've got granules in your abnormal promyelocytes that give you a very high peak in side scatter. We will see on the next slide, because they have matured from the myeloblast stage, they are usually negative for HLA-DR and CD34, but they have a 117 that indicates immaturity, strong NPO, and then they have not yet developed or expressed the integrins and the markers associated with maturation in the granulocyte lineage. Commonly 64, that can make things even worse when you're thinking this might be monocytic or not. A prognostic marker, CD56, is often expressed. And then if you do have a microgranular APL, you might see 34 and CD2. So there's a picture of this very high peak in your side scatter, where your blast gate is usually right here at the bottom. And you can misinterpret this perhaps as some of your granular sites or hypogranular neutrophils if they're sitting a little bit here at the bottom. So this is the slide I was referring to, showing the maturation of your neutrophils. So initially in your myeloblast stage, you expect to have 34 HLA-DR 117, but here at the promyelocyte stage, you only have 117. So that's why we see that that pattern, and also dim underexpressed CD15 in APL, and the cells have not gained 11B, CD18, CD16, for example. Just a quick note on APL-like flow. Flow cytometry is not specific. You cannot make and base your diagnosis of APL on flow alone. You can actually, in NPM1 and FLT3 mutated AML cases, have APL-like flow cytometry findings, and you need to correlate with your morphology and await your urgent FISH to confirm 1517. In these AMLs, you can actually have DIC diagnosis and also some similarities regarding the morphology that make things even worse. So definitive diagnosis with a demonstration of translocation 1517 is what you want to go for as soon as possible. This can be done on FISH, which is faster. Cytogenetics, which you do have to request anyway, will show you if there's additional cytogenetic abnormalities. Translocation 8 is often seen. And then, as I mentioned, quite a number have got additional FLT3 mutations, but the prognostic significance is not proven for these. And since cytogenetic testing and FISH do not determine the isoform of APL that you're dealing with, you need to send reverse transcription PCR testing at diagnosis as well for this PML-RARA transcript. At diagnosis, a standard PCR can be performed to identify the isoform, and they then see if you're dealing with a BCR1, a BCR3. Those two are more common, or the rare BCR2 variable isoform. And this is important to plan for your MRD monitoring later on, especially if you're unlucky enough to have a patient with BCR2, that it could be very difficult to identify later on. So it's important to know what you're dealing with. For us here at Grootskier, it's important to remember, and I'm sure elsewhere, this needs to be submitted on ice. A bone marrow aspirate is preferred, needs to arrive within 24 hours. And unfortunately, if the result will not be reliable, it's old, it's not on ice, we are going to reject it, or actually the cytogenetics lab, so don't blame me. A quick slide on why ATRA, which is all-trans retinoic acid, and ATO, arsenic trioxide, actually works, and where they bind and how they function. But you guys can read this on your own. For both of them, there's degradation of PML-RARA and proteasomic degradation. The one binds to the PML moiety and the other to RARA. So brilliant drugs, and lovely example of translational medicine. High-risk APL, based on the Italian large cohorts, Pathema and Jaimima, they gave us the SANS risk score that tells you risk of relapse, and based on platelet count and white cell count at diagnosis. Subsequently, these have been condensed into just having your white cell count more than 10 would make your patient a high risk case, and if it's lower than 10, standard risk. Also, CD56 expression, age, I see has become less of a factor if you have got a patient without a lot of comorbidities. Important with your risk stratification, remember that those variant RARA translocations that really occur can impact your responsiveness to ATRA. So your 1117 is not responsive to ATRA, and you treat as an AML that's not an APL, and 1717 also has resistance to ATRA. So this is my quick slide on an overview of the treatment of APL. Perry will afterwards give you guys much more detail and more relevant information. I'm also not going to talk specifically about support for the coagulopathy or looking at your differentiation syndrome. So please look at those on your own. So for APL, your principles are early diagnosis, targeted therapy, aggressive support. Think about and manage and look for treatment-related complications and do appropriate MRD monitoring. You are looking for an experienced team to give you advice and to manage this patient. You start your ATRA and your support based on a clinical picture, FBC, morphology, your DIC screen. You cannot wait for confirmatory tests for the 15-17. At the moment, the guidelines state that for standard risk, ATRA and ATO alone are actually the recommendation and have been proven non-inferior to ATRA with chemotherapy, less myelosuppression toxicity in infections, and actually less relapses, early deaths, and you can actually get ATO in a oral preparation, which is great. For high risk patients, there's not enough data on these two as far as I could see in my limited reading, but we'll see what Perry says. Usually there's still chemotherapy, anthracycline-based chemotherapy linked to ATRA, so those two are given. Hydroxyurea for hyperleukocytosis at diagnosis, Decadron to prevent differentiation syndrome, and CNS prophylaxis. This induction protocol is not altered based on your specific PML-RARA isoform or your expression of, let's say, CD56. Your aim with induction is to reach hematologic complete remission or CR, and then go on to molecular remission, which is sometimes only attained by the end of consolidation. So we'll talk about that in the next slide with MRD monitoring. We mentioned the appropriate support, looking for drug side effects, which can be very detrimental, and the role of maintenance chemotherapy is still debated in patients who start off with ATRA and ATO. Relapse, you've got a number of different options, also depending on what you started out with. But ATO is the standard for salvage therapy. And then in pregnancy, of course, you need to have very specific considerations. In trimester 2 and 3, you can go on to ATRA and chemotherapy. So that's just my little blurb on the background or an overview of APL treatment, and Perry will tell us more. I refer you to these two papers published in 2019 that gives lovely information, and especially for us in the laboratory where lots of this is theory and we don't deal with treatment of APL on a daily, weekly or monthly basis, luckily. MRD monitoring, and I'm almost done. We use MRD monitoring for the prediction of treatment failure or relapse. And as we said initially, you're going to do the PCR and determine your isoform. And then for MRD monitoring, reverse transcriptase, qualitative real-time PCR with hydrolysis probes is what you do to detect the presence or absence of your PML-RARA transcript. At GSH, we have a semi-quantitative assay. So as I said, remember that you may fail to detect the variable isoform. So if that was not identified at diagnosis, you may think that you've reached your molecular remission, but you're testing or you're not actually identifying your isoform. For our purposes at GSH, 0.1% or higher are called as positive. And if you do detect MRD, we repeat in 2 weeks with another sample to confirm. FISH for MRD monitoring does not link to active disease and lack sensitivity, which is why it's not recommended. And I touched on this before, the time point for MRD monitoring is at the end of consolidation. That's the most important. So unless you're doing research, the value of earlier MRD monitoring can actually be confusing, or it can be confusing, and the value is debatable, and it should actually not alter treatment. So initially, your PML-RARA transcript can remain positive, and you can get confused and think that you actually need to alter your treatment, whereas it just takes time. And at the end of consolidation is the time for you to have a look. Literature varies, and I'm sure guidelines and protocols as well, but 3 monthly testing after consolidation for 2 years is required or advised. Longer for high-risk cases. They say if you gave your patient Atran-ATO, you can actually stop monitoring when you've achieved molecular remission in the bone marrow. It is practical to test MRD on peripheral blood, but bone marrow aspirate remains the preferred option. And that's my summary. Last slide, you guys saw on my very first slide that APL is inevitable. If you're working in the laboratory, if you're working in hematology, in the clinical field, APL will find you. A low or normal white cell count does not mean all is well. If a slide comes your way that's flagged for low platelets, be comprehensive, scan the blood film. If you see anything that looks suspicious, look at many of them so that you can be sure that you looked for features of APL. Do the DIC screen and talk to an experienced team. So talking about experienced team, I will now hand over to Perry, unless there's questions, and I will have a look in the chat.
Delene, that was brilliant. Thank you. What a fantastic summary of a very big topic. So before we move over to Perry, there was at least one question in the chat, and let's see if any more arise. I see Tanya has a question that Delene, you can likely read yourself.
Yes, I see the question from Tanya about the PAX gene tubes. Tanya, I'm sure we do have these. I unfortunately am not firsthand with the PCRs and exactly what their SOPs say, but sure, I'm very happy to check with Karen Shires about PAX genes. I think for our in-house samples that we send down from our bone marrows, it's definitely possible to do as described in the slides, to get it down to her stat on ice, and they can immediately carry on. But if it is sent from far away, definitely this is a good option. But unfortunately, I am not completely proficient, but I will look into that for us.
Thanks, Delene. Any other questions for Delene? Okay, so I think there will be room for questions during and after Perry's talk as well, and I suspect there's going to be some common themes during your respective talks. So let's move on to Perry's talk now. Thank you very much. Assuming Perry's there. Oh, great. Wonderful. Welcome. Here. Thank you. Welcome.
Hello, everyone. Just thought I'd switch on my video that you can actually see a face. So I'm just going to make this full screen. Is that good? There's always the sort of, are you seeing the presenter mode or the correct side of it?
So Perry, right now we can see the presentation mode where we can see your next slide, if you know what I mean. I don't know if that's what you want. You know, it's got a composite screen.
No, not.
Oh, that's better, much better. Good.
Okay, great. So I've decided to just talk about how to cure APL. It's, I think, not common that a hematologist says that he cures disease with such conviction as what we can say about APL, but it is true. It is one of the most highly curable leukemias. So we were very excited to be able to treat these patients in the best way possible. So what I thought I'd do is just talk over some sort of data and hallmark studies on the treatment approach to APL with particular reference to chemotherapy regimens. You know, we've got an SOP on which at least encompasses supportive care, amongst other things, in the management of differentiation syndrome that you know, we can maybe share afterwards if there's enough time. But those are pretty standard things. So this is a study that was published very recently now in clinical lymphoma, myeloma, and leukemia by, you can see they're quite familiar names here. I'm not an author on this paper, and so I've got no horse in this particular race or any conflict of interest here, but it's a privilege to present some local data for a change. And this was a retrospective study of APL patients who were treated at Groote Schuur in basically a 20-year period. And approximately 69 or 70 patients, 69 patients were treated during this period, all with confirmed APL. The vast majority of which were treated with the Pethema LPA 99 protocol, which basically is the standard, or was at the time for a long period, the standard chemotherapy regimen of ATRA with anthracycline. And we routinely substitute the idarubicin for daunorubicin, just because it's more easily available. Following induction therapy, consolidation is repeated cycles of idarubicin, and second consolidation is with mitoxantrone. And then patients after this go on to maintenance with low-dose chemotherapy with 6-mercaptopurine, methotrexate, and ATRA for a 2-year period. So this protocol was given to the majority of patients on the study. A few received arsenic-based therapy, normally because of maybe anthracycline-related cardiac dysfunction. This table shows the baseline characteristics, and it's a pretty young cohort. And you can see about 30% approximately of the patients had high-risk APL. It's always important to draw this distinction because the treatment approaches for low-risk APL and high-risk APL have become a little bit divergent, which I'll go into. And then, as always in South Africa, we have our little group of HIV-positive individuals, which has actually, this is one of the first, or as far as I think any of us are aware, the first report of a group of APL patients who also have HIV. So I'm going to just move on. In APL, one of the major issues in both the practical treatment of a patient and also in doing research about patients with APL is that there's a significant percentage of them that die early, and this may be within the first week or within the first 30 days. So and oftentimes these patients are excluded from randomized controlled trials, typically under the guise of them having too poor a performance status to be enrolled. So oftentimes you need a ECOG of 0 to 2, and if you've had an intracranial hemorrhage, I can guarantee you will not fall into that group. So here, however, these patients were included in the analysis, which is a very robust thing to do. And you can see about 13% of APL patients died within the first 30 days. Of these, 4 were due to intracranial hemorrhage, and all of these patients died within the first 24 hours. And I think any of us that work on the clinical side have been confronted by this rather devastating presentation of APL. This patient with cerebral infarction died in the first week. And then, so, these patients really didn't really receive any therapy for their APL. And the majority of them had high-risk APL. So high-risk APL poses a significant risk of early death. However, in those who went on to remission induction therapy, the induction rate of death was 8%. Thereafter, on consolidation, no patients died in the 3 cycles of consolidation chemotherapy, which really shows you that the crunch time is the first month of treatment. So here you can see some curves of OS, and if you look at the top one, this is with all patients, including those that died early in the first 7 days, and then the bottom one is excluding the patients who died in the first week. And if you look at the 3-year OS of 82.5%, and you compare that to the original publication of LPA 99 in Blood in 1999 by the cooperative group of Pethema, Jemima, all the Europeans, you see that it's almost exactly the same, which is always quite satisfying, I think, to see. So these results are really, really good. In terms of sort of other outcomes, we had a 12% rate of differentiation syndrome, which wasn't really affected by the use of differentiation syndrome prophylaxis. There were hemorrhagic complications in 13%, and interestingly, a higher rate of thrombotic complications, which were non-fatal, but 2 stroke, 1 myocardial infarction, and 2 critical limb ischemias. So these were quite massive morbidity from thrombosis, and I believe one of these patients is now a bilateral amputee who still follows up with us now in the GSH clinic. Of those who failed treatment, over and above what I've described already, 6 from early death, those that died after consolidation on maintenance, there were 6 of them, and 1 was a relapse. 1 is an anthracycline-related cardiac failure, so that speaks there to a treatment-related mortality, as well as the sepsis and the disseminated TB could also be considered therapy-related as a consequence of the maintenance, likely. And the nasopharyngeal carcinoma it's quite questionable whether that, or could be debated whether that was treatment-related or not. And then 5 patients out of the cohort relapsed after a median of 25 months. And these, almost all of these patients, I believe, had some problems with follow-up and didn't complete maintenance therapy, or had substantial protocol deviations where they didn't complete the initial induction consolidation chemotherapy. So, and then here's just a comparison of where we stand in terms of our rate of early or induction death of about 8%, and really compared to other, one draws easily comparison to other countries in the developing world, where we have data from Brazil, where they have a much higher rate of about 30% of induction death. I'm going to elaborate on what IC-APL is, but basically this was a study performed to try and improve the outcomes of patients with APL in developing countries, particularly South America, and there they did substantially better. And but even the Swedish and in the US, in this relatively similar sized group of patients, had much higher induction deaths. So that's all, I think, very reassuring and nice to see that I think we do pretty well with our treatment regimen. But always we have to ask, how can these results be improved? So the first question that I'd put out there for us to debate is really, is early death preventable? And does your choice of chemotherapy affect the rates of early death? And I'll make some points to that as we go on. And how do we best prevent relapse? So as Delian showed in the LPA 99, where there was that, she showed that risk stratification of high risk, intermediate, and low risk. Her slide showed that the relapse-free survival of high-risk APL was 70%. So a significant number of patients with high-risk APL will relapse on that therapy. So further modifications have been performed of this protocol where you have a more risk-adapted approach, which I'm going to present. And then, of course, arsenic trioxide is the sort of, we're all about the chemo-free these days. So whatever that means. So, that has, we have to find out what the place is of arsenic. And if you, is maintenance really necessary? Also not sure about that. So following on the LPA 99, the same cooperative group of from Pethema and Hovon made a few adjustments. So you can see LPA 99 ran from 1999, as the name would suggest, to 2005. And LPA 2005 was the subsequent protocol, which ran from 2005 to 2009. And they gave the same induction, but there were a few changes in consolidation therapy. So basically the idea was that relapse-free survival is really good in low and intermediate risk patients, so let's give them less chemotherapy. And in high-risk patients, the risk of relapse is problematic, so let's add cytarabine to consolidation. And then patients went on to the same 2-year period of maintenance. So this is now from a different study, and sorry to sort of flip-flop between them, but this is the ICAPL data, which was basically a modification of this LPA 2005 for developing countries. And this is basically what I would base for a South African context, the modern ATRA chemotherapy approach on. And this was a sort of study that was conducted in South America where they basically just used the same protocol and swapped IDA for daunorubicin. But this is a nice table to have handy where you can see that in both low, intermediate, and high risk groups, there's some slight differences in terms of the dose of anthracycline. But most importantly, in young high risk patients, we have the addition of 1,000 milligrams per meter squared for 4 days of RSC in consolidation 1, and the same, a lower dose of 150 milligrams 8 hourly in consolidation 3. And here you can see, and this is the single arm data of pretty high overall and disease-free survival, which is what you kind of see across the board in APL studies, is that the patients did really well. But going back to the LPA, looking particularly at the difference in relapse rates between high risk and high-risk patients in LPA 99, when patients didn't receive cytarabine versus those that did in LPA 2005, you can see there was a significant reduction in the risk of relapse. Unfortunately, it's worth pointing out that this is a cross-trial comparison, which is a recurrent theme in leukemia research. But that does, to a certain extent, limit the meaningfulness of these findings, but it is pretty standard to do so in clinical trials in hematology. But there you can see they have a nice clinically significant difference. And this is now just across the board, irrespective of risk group. The curves do separate, but the p-value is not completely significant, but the modifications in LPA 2005 were considered superior to that of LPA 99. So that sort of is the basis, I think, for modern ATRA chemotherapy approaches outside of the US. And Matthew can maybe comment on the approach in Canada for ATRA chemotherapy. Then moving on to arsenic trioxide. This publication is from the NEJM in 2013. And again, the German, Australian, or European cooperative group study, where they basically this was a phase 3 multi-center randomized controlled trial with a non-inferiority design, looking only at low to intermediate risk APL, so those with a white cell count less than 10, comparing LPA99 to ATRA and arsenic trioxide. And this is also given this designation APL 0406. So this is the treatment schedule. We've already covered the ATRA chemotherapy, what that looks like, but that was pretty standard. And then patients got arsenic trioxide in induction, basically 0.15 milligrams per kg daily until they were in a remission. So that could take a number of weeks. Often more than 4 weeks of treatment in combination with ATRA. And then once obtaining a complete remission, they received weekly arsenic trioxide 5 days a week, again, dosed daily for 4 weeks, for 4 blocks of 4 of these consolidation cycles, each with ATRA in between, as you can see with this schedule. And here's the curves. I mean, I didn't show you the baseline characteristics for the sake of time, but there's not, there were well-balanced groups. There wasn't much methodologically at fault there. And I mean, this was, I think, overall an extremely well-conducted trial. And at an event-free survival at 24 months, so including relapse and death, you have basically on arsenic trioxide a 97% EFS. So that's just 2 patients who relapsed out of this group of basically 80 patients, where there was significantly more relapse under ATRA chemotherapy. I did some back of the envelope calculations here that you would have a number needed to treat of about 9 APL patients to prevent one of these sort of composite events. Now that number one could use to inform the cost considerations. And, we probably treat, I guess, 3 APL patients a year. So whether having ATO on hand at all times to treat these patients is a feasible approach is I think, quite questionable. But nevertheless, it's superior in both EFS and OS. And here you can see hematological toxicity in terms of platelets on the left and neutrophils on the right. And as it stands, with good reason that you see less cytopenias with ATRA and arsenic trioxide, which does translate, I think, quite significantly into lower health resource utilization. And these treatments can predominantly be, at least after induction, be provided as outpatients. Whereas you can see here in second consolidation, you've got quite significant cytopenias. These patients will most likely be inpatients at some point. So that's other kind of distinct advantage. But arsenic trioxide is not without its problems. The 2 major issues are hepatotoxicity. So about 60% of patients had grade 3 or 4 hepatotoxicity, which required dose modification. I don't think there were fatal events, and it was generally manageable with either dose cessation, temporary dose cessation. And then QTc prolongation is also something to look out for. And, where we do twice weekly ECGs on patients on arsenic trioxide and twice weekly liver enzymes. Here's data from the UK now using arsenic trioxide and ATRA on basically for all risk groups. So this included a cohort of high-risk patients and that was the AML 17. And basically what they randomized to was atra and arsenic with a bit of a different dosing schedule, I think a somewhat more convenient dosing schedule with a higher dose of ATO for 5 days, followed by twice weekly rather than daily dosing for 4 weeks. So when we use ATO, this is the regimen that we adopt because we've got less outpatient visits. Patients generally either come on a Monday or Thursday or a Tuesday and a Friday for ATO. And that's quite manageable. And just remember that some of our patients struggle with simply the costs of transport to the hospital. What limits the extrapolation of these findings, however, is that high-risk patients received a single dose of gemtuzumab. Now, the major reason that ATO isn't utilized widely is that it causes differentiation, and you may develop leukostasis and differentiation syndrome in high-risk patients. So they need some cytoreduction. And the author, that when they planned this study, this is what they decided on using. Whether it adds anything to the survival, I'm not sure. And they compared it to our standard, the standard of care, basically at the time, or LPA 99. And actually the primary endpoint of the study was quality of life, it was actually a negative trial that ATO-ATRA didn't give better quality of life than chemo, which I think is interesting. But I just wanted to point out some secondary endpoints for the sake of our discussion on the optimal treatment in terms of cure. That it's worth noting here that there was no significant difference in early mortality in the first 30 days. So this speaks to the fact that I don't really think that one of these two approaches lowers the risk of induction death. And furthermore, you can see that there was benefit to arsenic trioxide. In terms of a lower relapse rate, you can see here 0 molecular relapses in the arsenic trioxide group versus 27%. The absolute difference in survival is quite small here. And you can see the hazard ratios cross 1 and the p-value is not significant. So, this probably speaks to the fact that most of these patients who relapsed went on to receive atra and arsenic trioxide. So it's important if you're evaluating the OS curves and data in clinical trials and hematology to always consider what the patients would receive next. And if you're treating a disease that's got a very effective salvage regimen, you will obfuscate benefit in overall survival. So just a sort of a pointer for guys looking at trials in your training. Okay. Basically the curve, it looks like there's just one curve here, and that's because the red curve is a flat line at the bottom of hematological and molecular relapse. So it's clear that atra and arsenic trioxide is effective for all patients. I think I've already discussed OS. Here you can see that high-risk patients that there was no significant difference in overall survival for high-risk patients, and where there was a small difference in low-risk patients. But again, for the whole cohort, no difference. So, so far my reading of this is that ATO is a very effective combination and can be used in all risk groups, but you need to add cytoreduction to high-risk APL. But you would probably salvage the majority of these patients successfully if they relapse after atra ATO. So without a clear OS difference in all risk groups, I think you've really got to ask whether the costs in our low income or apparently medium income environment is acceptable. So here's the Australian data. I'm going to just flip over this very quickly, but basically again, proof of concept here that you can treat the 20% high-risk patients in this cohort, where they gave ATRA-ATO plus they gave anthracycline. In consolidation, they gave 2 courses of ATO and then used maintenance. And this was a very effective regimen. And subsequently, there was a protocol modification to change the consolidation to 4 courses. And this allows one to omit maintenance therapy. So that's another significant advantage of ATO-based therapy. And I think this is an important message on ATO treatment, in that, which I've probably already made this point, but here is stratified by white cell counts. You can see that the relapse rates for low and high risk disease are the same in this cohort, which is different from the data of chemotherapy, where, as I've already mentioned, on LPA 99, relapse-free survival was 98% for low risk and 70% for high risk. So yeah, you are preventing a significant rate of relapse. Although these events are uncommon, you can see quite small numbers at risk at the end of the day. Yeah, okay, the different curves here were this is again compared to a previous protocol, which was chemotherapy ATRA. So they, compared to historical data, there was an improvement. And this is the last study I'm going to show, which will give us some time for discussion. And if there's questions about supportive care, maybe we can answer them then. But another important group now from the US, basically showing, I think, a very similar picture where you can include ATO in consolidation. So after chemo ATRA induction, and you can see the curves here. These lines are quite difficult to see, but this solid line is arsenic-treated patients who are high risk, and this dotted line is high-risk patients who didn't receive arsenic. So, clear reduction in the relapse-free or relapse rates. So, in summary, APL is a highly curable malignancy. Treatment failures, however, occur either as manifest by death during induction therapy, which is most often early and often, in my experience, prior to the administration of any chemotherapy whatsoever, which leads me to the conclusion that there's no evidence that the specific chemotherapy backbone improves this metric. Relapses, however, less with ATO-based therapy, and that the prognostic significance of high-risk disease in terms of relapse may be overcome by including ATO. And the further refinements that ATO allows is the avoidance of maintenance therapy, the opportunity for more outpatient-based treatment, and the avoidance of hematological side effects, which may be quite costly and burdensome, although there is, at least according to AML 17, no evidence of a quality of life benefit. So that's the end of my discussion and overview, and I hope we've all gained a bit more insight into treatment protocols for APL.
Perry, that was excellent and perfectly timed, and the content was, I think, appropriate. Both you and Deline have now given us about 15 to 20 minutes of time for questions, and there likely will be some substantial questions asked about this. There was a question from Professor Lowe on the text, where he asks very appropriately whether anyone in South Africa is performing any research in APL. And I would add that is that laboratory based or clinical? You certainly have lots of opportunity to ask questions there. So maybe I'll open that up to the larger group to see if there are any comments on that.
Hi, Matthew. This is Charlene. How are you?
Hi, good to hear from you.
So we aren't really doing any research, but I'm hoping to finish my collection of my data for my master's. And I will probably be able to give you an insight of what is going on in KZN by next year. We have, I think one of the important things to actually mention to the registrars and the lab colleagues that are on the call is that, early referral and communication between the lab and clinical staff is so critical for this condition, because we've recently had cases, with the COVID pandemic adding to the mix of late presentation. I think it's paramount that communication of these urgent cases are, communicated rapidly, so these patients actually can be managed timeously. Because we've also have pretty much, from what I am seeing with what I'm collecting at the moment, that what Cape Town has seen with more than 80% remission rate, we're definitely seeing the same. Our numbers per year probably are a little more. Our population is higher than Western Cape. Yeah, so.
So yeah, I'm going to just add to that. Thank you, Charlene. I agree with everything you've said. I'm going to add that two things. I agree that, and hopefully you don't disagree with me in general, is that this is one of those conditions where once you suspect APL, a definitive diagnosis is not required before urgent referrals and initiation of ATRA treatment is indicated. So in other words, this is one of the malignancies where shooting from the hip is acceptable at the beginning, especially with two things: the use of preemptive ATRA on suspicion, and secondly, liberal transfusion support if you are suspicious of DIC. In other words, I think it's okay to overtreat a proportion of patients once you've ruled out APL according to the lab-based criteria that Deline summarized. The other thing that I just want to quickly mention is that Perry very elegantly summarized the data from Rory Shane and Estelle's group in terms of a nicely low early mortality rate in the cohort of patients treated with critical care, and that's fantastic news. What remains to be seen, though, is what can be demonstrated for early mortality at a population-based level, because there likely is a small risk of some selection and referral bias as to who successfully gets to gets to a big teaching hospital. What is also important is those patients who may only land up in a community hospital or at a local physician or local doctor, where the management may not have been ideal. And that's also quite important. And some of the comparative studies that Perry summarized were truly population-based, which would have included patients who were not treated at big teaching hospitals. And that's a very important group, because they may not have had the right kind of upfront and aggressive types of supportive care that is needed in this disease. Estelle, I don't. Do you have a comment that you want to make? I know you've said it in the text, but maybe it's better if you actually speak as well.
Yeah, I have a sort of a confirmatory remark on what Perry said, is that if we look at the data from the best healthcare systems in the world, such as Sweden, Stanford, wherever, early death seems to be rather unavoidable in the first few days, because these patients actually already have it written over them when they arrive. So that is a big problem. I don't know of anybody, and would love to know if anybody has managed that. Perhaps you've managed that, Matt, but I've never we've never saved a patient who had intracranial hemorrhage with APL. I've never seen that happen. These patients usually present in a casualty, and they literally already develop this either when they come because of it, or they develop it in casualty itself. And then it's not really, there's really no room for early movement. But definitely to prevent deaths in the first few days, we all agree. If they don't have intracranial hemorrhage and you can do your due diligence and give the right products, and immediately starts with the combination of ATRA and chemo, or in some cases chemo and ATRA because of high white cell counts, or ATO and or some other measure to get your white cells down, then we know that, yes, we can definitely save. And that's what the Brazilian study showed, is that their high early death rate of 33% came down to 15. It halved when they had these early measures of immediately getting ATRA to the patient. So I don't know if there's private lab colleagues or from other state hospitals, but we definitely see less diagnoses of AML. I'm speaking of all AML in the last year and a half. So we do wonder what happens to these patients. And obviously, if it's an APL patient who may end up in a PUI ward, then I think that those patients will never make their way to us. Yeah, so that's just regarding diagnosis, I wanted to say. And perhaps there are some opinions. Would love, Charlene also has something to say, but let me leave that to you, Matt.
Yeah, so Estelle, thank you. You raised some very important comments there about AML diagnosis and management in general, and APL specifically. And I'd love to hear comments from the other participants today about this. What is happening to the dynamics of AML diagnosis, referral, and treatment in the last 18 months of pandemic? And obviously my concern, and at least witnessed here in Canada as well, is patients' reluctance to seek care for symptoms, which for many cases of malignancy is a concern, but probably has its greatest concern in APL, where even 1 week delay in diagnosis can result in mortality, accounting for the risk of hemorrhage. So this is another opportunity for more outcomes and epidemiologic updates. I think that Estelle's group set the scene nicely with Rory's publication from last year, but there's definitely room for more, both with respect to APL and actually AML in general. I'm going to just see, so Dr. Creel did have an update with respect to a question that arose earlier about diagnostics. Delene, could you update us? I think you wanted to discuss the PAX gene question.
Yes, just 2 sentences, Matthew, thank you. I contacted Prof. Shires, who is fluent in molecular speak, and she just confirmed that the PAX gene is definitely a very viable option and can lengthen your delay until receipt of your sample. For our specific case here at Groote Schuur, the main considerations are cost and being economical and efficient. So to change over from the current way we're doing things with the EDTA tube, she says a specific new extraction kit would be necessary, and that would only then be used for this assay. And you can't swap between the 2 different tubes. And there's also been some reservations in the literature about the PAX gene use for BCR-ABL, which I don't know much more about. But those are the reasons why we are sticking to EDTA on this side. However, if you've got the extraction kit and you've got yes, the money for the Paxgene tubes, then definitely it's a very good option.
And thank you, Darlene. I think Charlene Parsanath also had a comment. Charlene, sorry to overlook your earlier hand up. Are you still with us?
Yes. So I agree with what Estelle said about the intracranial bleeds. We need to actually try and, get these patients before that happens. But we've had maybe 1 or 2 cases where these patients actually, we've managed to salvage them. And so, it's not that we totally write them off, but it's really, really important these patients get to us as soon as possible. And the comment you made about starting ATRA, even at the base hospital, if it's available, and treating the DIC and getting the platelet count. Obviously, the threshold is different with we have to be a little more liberal with platelet transfusions in these patients. And this is what we found actually help those patients that present with the intracranial bleeds. The ones with the massive bleeds probably may be unsalvageable, but the ones that have maybe multiple little bleeds, we've managed to actually salvage a few of these, but it's not that many.
Thank you, Charlene. I'm going to just touch on this transfusion question, just to see if there's feedback from the group about that. I've got 2 questions related to the bleeding diathesis. Number 1 is, in South Africa or in the various hospitals and regions, is there a tradition of using cryoprecipitate for the hypofibrinogenemia of the DIC, or does South Africa use fibrinogen concentrates, or that? So that's question 1. And question 2 is, in the situations of DIC, what your approach is to either the use of heparin or tranexamic acid. So a fibrinogen concentrate and cryo question, and a tranexamic acid and heparin question. I just want to just sort of clear those questions up for everyone.
I don't know if I may answer, or Prof. Lau, you were unmuted there, so let me.
No, Perry, I think you can answer. Please go ahead.
Yeah, so we use cryoprecipitate routinely. I think that I'm aware that's the standard. Well, that's certainly the standard of care for Grooteskier and in Bloemfontein. And Charlene, I'd be surprised if you had fibrinogen concentrate. I don't even think that's registered with SAPRA. So yeah, that's that. In terms of cyclocapra or tranexamic acid, we avoid its use in APL, in DIC, and I think our data supports that, in the sense that our thrombosis rates are already 23%, and I think there's sufficient concern that that would be higher if we routinely use tranexamic acid. So almost feels to me that once you pass the first week of treatment and you're on supportive transfusions, the risk of thrombosis actually starts to outweigh your risk of bleeding. And then I'm going to leave your question about heparin open, because I haven't ever used it for DIC in particular. I think perhaps if there was established thrombosis, we would, but not prophylactically, I guess.
Yeah, thanks, Barry. I mean, I bring these questions up provocatively to sort of air them. Were there any other questions? Any comments? Sorry.
So with regards to KZN, we actually have access to freeze-dried plasma, so it's readily available. So oftentimes when we accept these patients into our units, and if we suspect they may be having DIC or we confirm DIC, that's a product we use. We do use cryo occasionally, and tranexamic acid, as Perry said, we also do not routinely use it, and heparin as well. Except we actually have one patient in our care at the moment, a young male, that after 2 weeks, we noted he developed a DVT. So when his platelet count was safe enough, we commenced him on enoxaparin, but it's not routinely used in our unit. So we tend to favor FDPs just because it's readily available, and yeah.
Okay, that's good to know. Thank you. And so thank you very much for the comments, both Charlene and Perry. I mean, I think most of the big international guidelines would support your contention that both heparin for DIC and tranexamic acid for DIC are not recommended. There's just insufficient evidence that they're helpful, and there may be some evidence that they're harmful. I bring up tranexamic acid because as a drug for bleeding, it has become increasingly popular in recent years based on the very large data showing that it is of benefit in situations of massive trauma, perhaps in obstetrical bleeding, etc. So in the world of general hemostatic support, I think that medication is becoming much more familiar to everyone, and there's a risk that tranexamic acid could then slide into use in an APL patient who has massive bleeding, and I would caution against that. Same with heparin. I do want to make a quick comment about ATO in this part of the world, in a so-called wealthier part of the world, although everyone's very vigilant about expenses. So based on the GEMEMA European randomized trial that Perry so nicely summarized, arsenic trioxide has found its way as a frontline agent in pretty much every APL patient. For those with high risk APL, the funding for it is highly variable from region to region, at least in Canada. And so there's a process of individualization there. Sometimes those patients with high risk APL are so sick appearing that we've said that we thought that anthracyclines or any other chemotherapy would be contraindicated. And so we've justified using the ATRA-ATO route for high risk APL simply because we didn't think that anthracyclines was safe. So we've sort of squeezed that indication, perhaps a little bit unfairly so, but we're trying to give arsenic to everyone. If we land up using a chemotherapy regimen for high-risk APL, we are basically mimicking the Australian APL-4 regimen, where we are using ATRA and ATO up front, along with 4 doses of an anthracycline. And they used idarubicin. I think if you do use daunorubicin, it should be at a dose that you think is equivalent to the idarubicin being used. The US study that Perry nicely summarized had used daunorubicin at a dose that is probably lower than traditionally considered active in this disease. They used 50 milligram per meter squared. And as you know, there's a case in all of AML to try to use higher doses of anthracycline. So if daunorubicin is being used, I would use it at 60 milligram per meter squared dose rather than the 50, or at least 60 anyway. So just those quick comments from this side over there, from the Northern Hemisphere. Any other comments or questions?
I think a quick comment from me. Yeah, thank you to the speakers. I think these were really great presentations. I do have to say, so Perry has designed an APL protocol for us that we've now been using. We've actually been treating our very first young 22-year-old with standard risk APL with ATO and ATRA combined. She's doing very well. But again, I saw the use of a good protocol And I want to leave a provocative suggestion / question to the audience. We are in the process of writing protocols at Groote for all the diseases, but it's obviously a massive task. And there's so much to do and there's so much to write about. And I want to challenge the whole South African community basically and say, like we've been doing this deep dive together, should we not consider the writing protocols together and sharing that with each other, that we don't all have to duplicate. Each one of us or each group can then perhaps adjust whatever protocols the others have made, to their own circumstances as needed. But at least the heavy lifting could be shared. So it's a question I have and a suggestion. You're welcome to throw your comments into the chat. But I think if we committed to all, jointly do this, I think patients actually do better if we protocolize what we do properly. I've seen it now with this patient, knowing about all the supportive care, monitoring the QT time, carefully looking for drugs that can prolong it, making sure that your electrolytes are always perfect, watching the liver functions. I mean, things that, you either know or you don't know, or your new fellows or new registrars may not be aware of. I think patients go through better and safer. And I think that so I want to thank Perry again for that protocol that he made us. It's really fantastic. And then if I can just quickly share something on my screen, I just want to show you this. This is a lovely paper, APL history over 60 years, from the most malignant to the most curable form of acute leukemia. Just want to show you two things, nice historical overview. And look here, 1977, Rowley describes translocation 1517. And I'm sure you'll remember that Rowley also described the BCR-ABL translocation, I think in 1973, if I remember correctly. And then here, the very first publication ever, just the front page, APL by this Dr. Hillestad, where he also names the disease. You can see at the bottom, a logical name for this type of leukemia is acute promyelocytic leukemia. Beautiful little description there. If you want to go and read this, this is from 2019 by Xavier Thomas. From my side, again, thank you, Matt, for leading this. It was awesome. Really enjoyed it. Back to you.
Thank you, Vernon. I think your comment about a unified national level protocol could not be a more important concluding comment. And of all the diseases in hematologic malignancy, this is the one. It is too uncommon for there to be too many variations in treatment approaches, and collegial interaction during the diagnosis and managing these patients is absolutely indispensable. And no one center will see enough patients to develop great expertise. So I would really strongly reinforce that if Perry and colleagues, Vernon and Estelle, etc., have already put a lot of effort into protocolizing, that you should consider trying to look through that and adopting it, because not only will that benefit patients, but of course there will be publishable evidence to demonstrate that within a couple of years. So I want to thank everyone, particularly the speakers, Delene and Perry, superb presentations. And I learned a lot from those presentations as well. And it is absolutely heartening and fantastic to see so many participants on these talks, because there is very little like this at the national level that you see in other countries. So well done, everyone, and particularly also to Estelle and her colleagues for organizing these meetings. So thank you, everyone.
Thanks, Matt.
All the best. Thank you, everyone.
Thanks, Matt. Thanks, everybody, for the great session. Thanks. Have a good evening.
Yes. Bye-bye, everybody.